Hi, I'm Dr. Vikram Kishore Reddy, Consultant Neurophysician, Medicover Hospital, HITEC City. Today we have with us Dr. Aneel Kumar, who is a Consultant Neurosurgeon at Medicover Hospital. And today we'll be discussing about Deep Brain Stimulation, how are its effects on the brain, where do you do that, and దాని ఇండికేషన్స్ ఏంటి, దానివల్ల ఉపయోగాలు ఏంటి. సార్, బ్రీఫ్గా చెప్పాలి అంటే DBS గురించి ఏం చెప్తారు?
డీప్ బ్రెయిన్ స్టిమ్యులేషన్ ఫర్ పార్కిన్సన్స్ డిసీజ్ అంటే ఏంటంటే మనం విల్ జస్ట్ పుట్ 2 electrodes into the STN nucleus అని ఉంటుంది, అండ్ దెన్ వీ గివ్ కరెంట్ via a small battery. So that will act and that will trick the brain into believing that it has got some, and there will be change of circuits and it will trick the brain into being good. So దాంతో ఏంటంటే we can decrease the medications and the patient's symptoms అన్ని improve అవుతాయి.
So do you really feel that by doing DBS we are trying to increase the dopamine level in the brain and the body?
No. Dopamine levels they'll not increase, but the circuits which are there, the dopamine, the circuits which are involved in these pathways, they are modified in such a way that the brain thinks that there is dopamine.
Oh, great.
So that is how you will get the result.
So in which population of Parkinson's patient you would prefer? అంటే అన్ని Parkinson's patient కి అడ్వైస్ చేస్తారా, లేకపోతే are there any measures to look into it before doing that?
In this area, choosing the patient is important.
Yes.
Choosing the patient lo you are the one who are an expert.
Yeah.
If you think this is a patient who will really benefit with the surgery, then those are the patients who are very good candidates. So once we decide and then we do the few tests which will tell us whether the patient will have good improvement or not. Based on that we can decide will the surgery can be done or not. Usually what we prefer is 70 years above. Personally I am not very comfortable because at that point of time the non-motor symptoms will start to set in.
Yes.
But we have patients we have done in 80 years also. Okay. But it's on case to case basis. And then patients who do not improve with medical management or who have little atypical features, they don't do well with deep brain stimulation.
Like hallucinations, more non-motor symptoms, more
non-motor
falls,
symptoms, yeah,
more cognitive disturbances, and that is specifically atypical Parkinson's.
Atypical.
But if you want to give a hope to the patient, అంటే చేసుకున్న వాళ్ళకి మీరు hope ఇవ్వాలి అంటే, because money is involved and it's a little lengthy procedure, takes lot of time, lot of effort. So patient కి ఫీలింగ్ ఏముంటుందంటే once you do the surgery all the symptoms will be gone. అంటే నార్మల్ అయిపోతాను, నేను మెడిసిన్స్ పైన ఉండాల్సిన అవసరం లేదు. సో ఇలాంటి క్వశ్చన్స్ అడుగుతూ ఉంటారు. సో హౌ డు యూ కౌన్సిల్ for those symptoms?
దీంట్లో the best time when we can counsel and when we can discuss this is when we do the on-off test.
Yeah.
So when they are off, they know how worse they are.
Yes, true.
Okay. Then we give the medications and then they come to on stage.
Okay.
And in this on stage, they become really good. They can perform some activities and we do the score.
Yeah, we do the score, on-off score. How good the score improves after the levodopa test.
So what I tell the patients is your best on score is what you can expect.
Oh.
Beyond that you are not going to expect. For
Even
example,
with the procedure.
For example, in the on stage you are walking, that means you will walk. DBS will not make you run.
Okay.
If you are on a wheelchair, then you are on a wheelchair, that's all. It will not make you walk. Okay. So what is the best response in on stage? That is what you are going to get with the DBS.
Okay. So do you recommend to stop the medications once the patient is after the DBS? You do that, or because I personally don't try to stop the medications.
Yeah. So it's a different school of thought. As there are some people who will totally stop and totally rely on the current.
Okay.
And we are like our conservative people. We give medications and also augment it with the battery things. So as per the research, it says that 50% of the people on whom we do DBS,
okay,
50% of the people, 50% of the medications are gone.
Okay, so you mean to say you reduce the dose, or you stop altogether category of medicine?
Reduce the
dose.
So
you reduce the dose.
Reduce the dose. So you can expect, for example, you fall in those 50%, then your medications are gone by 50% down. Once the 50% of the medications are gone down, so your side effects of dyskinesia is gone.
And even pill burden, because most of them are like above 60 years, so they have hypertension, diabetes, cardiac medicine, so that pill burden will be lessened. So I think in that way they may be benefited with reduced number of dosages of the medicine. So if you want to counsel a patient, obviously they'll ask about the side effects, both డ్యూరింగ్ ద ఆపరేషన్ అండ్ పోస్ట్ ఆపరేషన్, ఎందుకంటే అది ఒక ఎక్స్టర్నల్ డివైస్ పెడుతున్నారు. సో దే హ్యావ్ దేర్ ఓన్ కన్సర్న్స్, అంటే అది ఎంతవరకు నమ్మొచ్చు, మాల్ ఫంక్షనింగ్ ఏమైనా ఉంటుందా హార్డ్వేర్ది, అండ్ ఎంత ఫ్రీక్వెంట్ గా బ్యాటరీస్ మార్చాలి. సో హౌ డు యూ కౌన్సిల్ దెమ్ అండ్ హౌ డు యూ మేక్ దెమ్ కంఫర్టబుల్?
So this part of counseling is very, very important because they are functionally normal people.
Yes.
Okay. And they have a disease which is limiting their lifestyle, but it's not causing something which is, decreasing their lifespan.
Exactly.
So in these patients, we have to be doubly cautious, doubly sure, and be very careful. If it is say for example, there is a tumor or some kind of, some other disease, then things are different. Here, we are doing the surgery to improve their quality of life. So that's why all the complications really matter.
Okay.
The first and foremost complication, and the one which is very problematic, is the bleeding. So what I say is, usually if you operate on 100 patients, 2 patients can have bleeding
during the surgery.
So that is 2% of the people. The 2% chance that they can have a bleed. In that, 1% of the people can have a major bleed.
Okay.
Requiring stopping the surgery or doing craniotomy and evacuate the bleed. So that is around roughly 1%. The other 1%, usually they have small bleeds, or you do a CT scan or an MRI post surgery and then you find a small bleed. Those are normal, routine. So for a patient, the bleeding is the one complication which is very, very dangerous, and it can cause some debilitation also. But the percentage is less. When compared to normal neurosurgery, this is very less. Okay. Then the other important complication is infection.
Because it's a foreign body.
So now we are keeping a device which is there in your body. It doesn't get dissolved.
Yes.
And it can get infection anytime. So the infection rates are around 5%. If you operate on 100 patients, some 5 people can develop infection. The problem with infection in these patients is the implant. Once there is an implant, when we start giving the antibiotics, we have to give for a prolonged time.
Only if it gets infected. Or prophylactic?
Infected. And then if it heals, it's okay. Most of the time it does not heal.
Oh.
And if it does not heal, then what we have to do is we have to explant it. We have to remove the device.
Oh.
So whatever you have spent, the money which you have spent is all gone, because you're removing the device.
Yeah.
But here what happens is we have safety devices where, for example, if only the battery is infected, we can remove the battery, preserve the rest of the things.
Yes.
If the extension wires are involved, we can remove the extension wires, we can preserve the battery and the leads.
Okay.
The only problem will come is when the cranial electrodes are infected,
which are there in the
brain. Then you have to remove the whole thing and do a fresh surgery again.
Oh.
So that is the problem with the infection. So what we usually say is, in patients especially with diabetes and malnourished people, then you should be careful.
Okay.
So infection is other thing. The other thing is the lead can, our target is very precise.
Yes.
Probably around 1 to 1.5 centimeters. So when we go there, you can deviate.
Yeah, the chance of
misplacement.
lead getting misplaced.
So what we have is this misplacement is also around 2%, 2 to 5%. So what we have is a series of things where we correct ourselves.
Mm-hmm.
So the number one is the moment we cross check. When the frame is mounted, we cross check with an assistant surgeon and with an external person. The frame settings, all we doubly check that.
Mm-hmm.
Number 1. 2 is you are there in the operation theater, so we go with the MER recordings.
Yes.
So as we go in, we record everything, and you can when the recordings are not clear, you are obviously there to tell us.
Yeah.
And then the third is we stimulate the patient, and during surgery, when the patient is awake,
and then that's when we see the symptoms.
We see symptoms.
Improvisation.
Those symptoms will improve. Then we can see the side effects.
Yes.
So at this point of time, you are almost dead sure that you are on the target.
Yes.
But then once this is done, once the lead is implanted, what we do is we still keep the frame and then shift the patient again to the CT gantry.
Okay.
We'll do another CT.
Just
come
to
back,
make sure that
it's in the target or not. So, and we fuse it again and see whether it is on the place or not. So these are the steps where we try to avoid misplacement. But despite all these, there are chances that it can get misplaced.
Okay.
So here what we do is, if the patient is affordable, we suggest to go for directional leads.
Okay.
So the directional leads, the even if we are misplaced by a small percentage, we can manage. So that is one thing. Then the other thing is implant failure. So now these are devices.
Yes.
We have a wire.
These are machine.
So the machine can go wrong. It can stop working. The company guys give some warranty, and if it's in that warranty period, probably they may replace it. But the wires can get fractured.
Oh.
So if these are there, then you have to see what is the problem and then troubleshoot accordingly. Then the other problem is psychiatric side effects. So usually what we do is we work up the patient initially.
Yes, we do that pre-surgical evaluation
Yeah.
with a neuropsychologist to see how the scores are.
Yeah. So once that is done, even then the patients can have some aggressive behavior or very calm type of.
So do you think is it because of overstimulation of the target, or because we do get this kind of symptoms with medicines and as well as the disease progression?
Yeah. So that is because of the target itself. Okay. So it has an emotional component. Yes. So, but in our experience, what we see is probably in around 1 year time post surgery, 50% of them will come back. They improve over time.
It's only time taking.
Yeah. So these are roughly the major side effects. Right. The other side effects, like having anaphylactic reactions and all those things.
Those are all like not that frequent.
Yeah.
And one more question, sir. Like, మనం ఎప్పుడైతే అది స్టిమ్యులేట్ చేస్తామో ఆన్ టేబుల్, we see very good response. So the same kind of response we don't get probably in next few days.
Yeah.
And there is again two thoughts, whether to put the battery on the same day and then stimulate on the early side or stimulate at the later side. So what is your take on that? And
that's putting a battery is a surgeon's choice. Okay. Like if you are trained at some place, and what they do is what you do. Yes. Ultimately. So there is no guideline key you should put here. So that is okay. You can put it immediately on the day of surgery or the next day, or some people will do it after a few weeks also. That is up to the surgical team. There is no nothing very specific to that.
Okay.
The other thing is what rightly you pointed is, initially the patient does very well. Initially, so this initial thing is there for probably few weeks.
Okay.
And then they start to go down.
Okay.
That initial thing is because of the micro lesioning. When we put the electrodes inside, especially the MER, there will be a small lesioning effect. Okay. That is the reason why they are very good in the initial days. Yes. But once the lesioning effect goes away, the patient will go down. And then we have to titrate. We do programming at that point of time. So that is the reason why we actually, some people don't do the programming initially. So they'll do the programming.
So let the lesioning benefit be there, and once it subsides, appudu malli chesi better.
Yeah. So that is how they do it. So in what we say is, usually it's around 9 months to around a year. Okay. Time where you titrate, you increase the current, you decrease the medicines, or increase the medicines, decrease the current, and at one point, one sweet spot, probably you'll leave
titrate. You have to titrate and then fix that dosage or even the settings in the battery.
So that is the time. That is why we tell the patients, you initially you need to come regularly.
Okay. Follow up.
Probably once we reach the sweet spot, then they are okay. Then they can come at a longer durations.